All right, welcome to this explainer. Today, we're going to dive into one of the toughest challenges in all of oncology, pancreatic cancer. The goal here is to give you a solid, clinically oriented framework that you can actually use on rounds, for your exams, or just to get a handle on the critical decisions we face with these patients. Let's jump in.
So right out of the gate, we've got to face the reality of this disease. Only about 15 to 20% of patients, when they first walk in the door, are even candidates for surgery. Think about that. That one number, it dictates everything that comes next, the urgency, the way we stage, and our entire treatment philosophy.
Okay, so here's our roadmap for today. We're going to follow the patient's journey from the very beginning. First, we'll get to know the enemy. Then we'll talk about decoding the clinical clues. After that, we'll navigate the diagnostic pathway, and then we get to the big one, the resectability question. From there, we'll cover the principles of surgery, and we'll wrap it all up with the key clinical pearls you'll want to remember. All right, let's jump right in. Section 1, a formidable foe. We need to know exactly what we're dealing with, and that means really understanding the most common type, which is pancreatic ductal adenocarcinoma, or PDAC for short. You know, it's really key to understand that when you hear clinicians talking about pancreatic cancer, 9 times out of 10, they're talking about PDAC. It's this really aggressive tumor that comes from the exocrine part of the pancreas, the part that makes all the digestive juices. And it makes up the overwhelming majority of cases. So this is our main focus. Okay, moving on to section 2, decoding the clinical clues. So how does this disease actually show up in a patient? What are the classic signs and symptoms? Because being able to spot these patterns, that's the absolute first and maybe most important step in getting a patient on the right track. Okay, this slide is absolutely crucial because it shows you just how much the tumor's location drives the entire clinical picture. Most tumors, about 60 to 70%, are in the head of the pancreas. Because of where they are, they block the bile duct early on, which leads to that classic textbook sign, painless jaundice. And ironically, this is a good thing because it gets patients diagnosed sooner. On the other hand, tumors in the body or tail can grow for a long time without causing any obvious problems, often showing up much later with vague stuff like weight loss or nagging back pain. And speaking of classic signs, here is a huge one for your physical exam, Courvoisier's sign. This is when you can actually feel the patient's gallbladder, but when you press on it, it doesn't hurt. So why is that? Well, think about it. A gallstone causes this sudden, painful blockage, but a tumor? It grows slowly. It obstructs things gradually, giving the gallbladder time to stretch out without all that acute inflammation. It's a massive clue that points you away from gallstones and towards a malignancy. All right, section 3, the diagnostic pathway. So once you have that suspicion, what's next? You need a system, a logical workup to get from suspicion all the way to a confirmed diagnosis and a solid plan. And the workup really flows in a logical sequence. You start with the simple stuff, blood work, like liver function tests, and maybe a basic ultrasound to check out that jaundice. But the absolute cornerstone, the main event for diagnosis and staging, is a special high-resolution CT scan called a pancreatic protocol CT. And finally, to get proof, to actually get a piece of the tumor, the gold standard really is an EUS, an endoscopic ultrasound, where they can pass a tiny needle to get a biopsy. So when you're looking at that CT scan, this is one of those classic signs you've just got to have in your back pocket, the double duct sign. It's exactly what it sounds like. A tumor in the head of the pancreas is in the perfect spot to squeeze both the common bile duct and the pancreatic duct shut. And when they're blocked, they both swell up or dilate behind the blockage. It's a beautiful and ominous sign of a mass in the pancreatic head. Now here's something that trips a lot of people up. ERCP versus MRCP. Let's clear this up once and for all. Just think of it like this. ERCP is therapeutic. The P is for procedure. You're actually going in with a scope to do something, like putting in a stent to open up that blocked bile duct. It's invasive. MRCP, on the other hand, is purely diagnostic. The M is for magnetic, or maybe think MAP. It's just a non-invasive MRI that gives you a beautiful picture of all the ducts. You can't fix anything with it. You can only look. Okay, let's move on to section 4. And listen, this is arguably the most critical decision point in the entire management of pancreatic cancer, the resectility question. This is where we figure out if surgery with the hope of a cure is even on the table. Seriously, everything comes down to this one question. And what's interesting is the answer usually isn't about how big the tumor is. It's all about its real estate, its relationship with the major blood vessels that live right next to the pancreas, like the celiac artery, the SMA, and the portal vein. So
let's start with the best case scenario, resectable disease. This means the major arteries totally clean, no tumor touching them. The big veins, like the SMV or portal vein, well, the tumor can be touching them, but as long as it's not wrapping around more than halfway, that's the 180-degree rule, and the vein still looks healthy, a surgeon can usually peel it right off. Then you have this middle ground, borderline resectable. This is where things get tricky. The tumor is getting a little too friendly with a major vessel. Maybe it's just touching a key artery, or it's wrapped more than 180 degrees around a vein. Here, surgery might be possible, but it's going to be a much bigger, more complex operation that involves cutting out and rebuilding that blood vessel. Almost all of these patients will get chemo first to try and shrink the tumor back and make the surgery safer. And that brings us to locally advanced disease, which basically means it's unresectable. This means the tumor is just strangling those major vessels, wrapping more than 180 degrees around a critical artery like the SMA, or it's completely blocked off a vein that you just can't rebuild. And importantly, this is even if there's no cancer anywhere else in the body. The local invasion itself is what makes surgery impossible. All right, section 5, let's talk surgery. Now remember that 15 and 20% of patients? For them, the ones with resectable disease, surgery is the absolute cornerstone of any chance for a cure. This right here, this says it all. The number one non-negotiable goal of the operation is to get an R0 resection. So what does that mean? It means getting the entire tumor out with a clean buffer of healthy tissue all the way around it. When the pathologist looks under the microscope, they see 0 cancer cells at the very edge of what was removed. That is the single biggest factor for long-term survival. So when we talk about surgery, there are basically 2 main operations, and again, it all comes down to location. For a tumor in the head of the pancreas, it's the Whipple procedure. And let me tell you, this is one of the biggest operations in general surgery. They remove the head of the pancreas, part of the small intestine, the gallbladder, the bile duct, the whole shebang. For tumors in the body or tail, it's a bit more straightforward, a distal pancreatectomy, which often means taking out the spleen too, just because their blood supplies are so intertwined. Okay, let's bring it all home. Section 6, clinical pearls and takeaways. These are the absolute must-know points to stick in your brain for rounds. Okay, rapid-fire review. Here's what you need to remember. 1, when someone says pancreatic cancer, you think PDAC. 2, location, location, location. It drives the symptoms. If you see painless jaundice, your brain should immediately go to a pancreatic head tumor. 3, the most important test you can order for staging is a pancreatic protocol CT. 4, resectability is not about size, it's about the vessels. Remember that 180-degree rule. And 5, if a patient makes it to the operating room, the one and only goal is getting that R0 negative margin. And that really leaves us with the big question for the future. To truly make a difference in this disease, where is the next breakthrough going to come from? Is it going to be from earlier detection, finding these cancers way earlier when more people are still surgical candidates? Or is it going to come from better drugs, systemic therapies that are so good they can treat this disease no matter when we find it? That's the central challenge driving research today. Thanks so much for tuning in.